So, so we've seen, we've been talking about the biometry in children and the other traumatic cataract secondary IOL implantations, and I'll be talking about multifocals and torics in children. We're dealing with a childhood cataract, a lot of therapeutic dilemmas, whether you should place an IOL or not. Like we were just talking now, discussing about what will be the ideal age. There is no ideal age. It's very different from individual surgeon. Based on the experience, they would prefer to place an IOL. Like the senior doctor there said that he would place a lens in a 4-month-old child, cutting the haptics. In a smaller eye, less than 10 millimeter of corneal diameter, then I would be a little skeptical in placing an IOL. So there's a lot of dilemma, and depending on the type of lens, like in sulcus, we prefer a 3-piece lens, and the biometry we already discussed. We do not have an appropriate formula which is dedicated to pediatric cataracts yet. And then management of posterior capsule, again, is very important, which unlike in adults, there's a tendency of PC opacification. And the general senses would be to preferably put a monofocal acrylic lens. If it is in the bag, you can use a single piece, or if it is in the sulcus, a 3-piece lens. And usually you correct for distance. For near, you give them near vision glasses. And when you're treating children, you have to convince the parents or the caregivers. They always have these questions like, my child should be having a good vision for near, intermediate, and distance. He has to play different games, sports, and good binocular single vision stereo acuity is needed. And one thing they say that my child be free from glasses. So you really have to sit with them, counsel them, and explain to them the need for glasses for these children even after the surgery. And coming to the premium lenses, the premium lenses do have a role in adult cataracts. In children, they are now kind of picking up and guiding, getting a recognition in the pediatric age group. So again, we have a lot of questions regarding how early to implant an IOL in a child, and then what type of advanced IOL technology you would use, and what is the role of multifocal accommodative IOL. Of course, has not been proven, and it's not advisable to do it in children because it's not very popular in adults as well. And then role of refractive surgery to fix the residual refractive error. So why multifocals? Like unlike in adults who are usually under the age group, presbyopic age group, so they already have lost their accommodation, whereas in children, sometimes this lack of accommodation can lead to abnormal visual development, which affects the stereopsis and binocular vision development. So when you advise a multifocal IOL in a child, there are certain requirements. Usually you prefer to do it in an older child, usually above the age of 8 years, and you need precise biometric measurements, precise IOL power calculations, and always aim at emmetropia or a small residual hyperopia of 0.25 or 0.5 diopters, and not usually more than that, then you will not have good results. And the patient selection, so do not do it in a very young child because you will have difficulty in predicting the growth of the eyeball, and you always undercorrect. We already seen in the biometry that undercorrect, keeping the myopic shift in mind, and always aim for a final refraction in adulthood. This is a video. This was a 10-year-old boy, Dinesh, who came with the intumescent lens, and we planned for a multifocal. I used the Varion guiding system for the centration of the capsulorhexis. This was an intumescent cataract. Do you have a pointer here? So you can see as well, we are trying to do a smaller rhexis and try to clean the cortical matter. It's better to debulk and do it, otherwise sometimes the rhexis can get extended. So keeping the Varion, for the centration, I'm doing a secondary capsulorhexis. You have to be very gentle. And there was a question regarding trypan blue inducing inflammation. We haven't seen any inflammation with trypan blue. So do a thorough cortical cleanup, which is very, very important in children, because if you leave something, then there might be a chance of proliferation and then after cataract. And especially when you do a multifocal lens, the centration is very important. You can see, and I still felt that sometimes when you leave the rhexis, it can cause capsular phimosis and fibrosis. So have an adequate size rhexis. And I'm trying to clean up the viscoelastics behind the lens. And I thought it's better to do because definitely this child will develop a posterior capsular opacification. So I'm doing a primary posterior capsulorhexis. Make a small nick. Use your ureters and then try to, you can see the posterior rhexis here. And we always prefer to put a suture, especially when you, disturb the posterior capsule. Here the vitrectomy was not done because it was an older child, so we could always, wait and watch. What are the merits? Rapid visual rehabilitation for both near, intermediate, and distance. And this will definitely improve the chance of binocularity in these children. And because there is the loss of accommodation is less, there is a reduced risk of amblyopia in these children, and there's also near vision is better in these children. And there is an expanded focal range to include intermediate distance as well when you use a multifocal lens. And then elimination for need for bifocals in these children, especially when children, you deal with children a little delayed who are not able to wear glasses. And then proper image focus in patients, like I explained, who are not able to wear glasses. The demerits with multifocal lenses, again, IOL power calculation predictability. So if you're dealing with children who are not cooperative and you're not having predictable results, and then it's better to defer placing a multifocal lens. Precise biometry, refractive stability is very important, so you cannot place a lens in a very young child. And visual development, because children do not complain, so you really do not know how comfortable they are, so that is one thing that you can sometimes hinder the non-optimum optic and hinder the visual development in these children. And then you will have centration issues, like, and postoperative complications sometimes can cause decentration of these lenses. And then possibility of dense amblyopia in unilateral cataracts. Unlike in adults who complained of glare and halos and loss of contrast sensitivity, children fairly do not complain much. So they usually withhold and they don't complain about the symptoms. So you should actually keep in mind about this. And sometimes the defocus image may lead to continued ocular dominance and create problems in children. And intraoperatively, you have other challenges, like you saw this particular patient. So you have to be very cautious in doing the rhexis because adequate centration is very important. There might be positive pressure you have to deal with. So, and then if you are doing in younger children, posterior capsulorhexis is very important. And if you're not, an expert in the technique, then sometimes you can treat with runaway rhexis and you may have to, defer the procedure. The other challenges, like we were talking about posterior centration, posterior capsular opacification, like this patient who had a repeated YAG capsulotomy with lens pitting. So all this should be kept in mind before you choose to do a multifocal lens in a child. These are all the studies which have been done. This is a little older study, but this was done with an array lens with Jacobi et al. And their group, they said that 35 eyes are 26 pediatric age group. And then in this study, they've shown that at least 10 of them required an IOL exchange. And at least 16 of them required a repeat membranectomy. So not very convincing. And Cristobal et al. Came out with another study with multifocal for unilateral cataracts in children. But there are certain, the participants were 5 children between the age group of 4 and 6 years. But then there were certain limitations in this group where there was no control group and the minimum follow was only about 21 months. So we do not know the long-term results. So, to conclude, multifocal lenses definitely is a good choice when you choose the right patient in an older child. But there are certain concerns like, there can be a refractive shift. There is a potential chance of degradation of amblyopia due to loss of contrast sensitivity. And then multifocal can definitely be an option for older children. And then you need further studies. But there are some studies also, I think, from PGI Chandigarh. And coming to the next talk is the toric IOLs in children. So we all know that naturally when a child is born, it is against the rule of astigmatism, which outgrows, and by the age of 4 years, they usually become neutral or become, with the rule of astigmatism. And again, when you become old, going for the against rule of astigmatism. So torics in children with cataract, it is very safe and effective way to correct the preoperative astigmatism, and it gives a better unaided visual acuity and reduces the risk of amblyopia. This was a study which was done in Japan with Watanabe et al. And they said that 65.7% of kids with cataract have astigmatism, and out of which almost 83% was with the rule astigmatism, and 5.1 was against rule astigmatism, and 11.1 was oblique astigmatism. So the indications would be usually children, older children above the age of 8 years, if they have astigmatism more than 1.5 diopters, And always prefer to exclude children with subluxation, big corneal scar, or any other keratoconus or any macular pathology. The investigations would be a corneal topography to rule out subclinical keratoconus. Always measure the corneal thickness, and you have to routinely follow these children for any keratometric cylinder. And coming to the procedure itself, the toric marking should be done before the induction of anesthesia, because it is better to do it in the upright position and using a topical anesthetic drops. Try to make the child understand and do the toric marking. So this is a video of a child with a toric implantation. Okay. So here you can see again I'm using the Varian. You can have a Varian measurement done for these children. I could see the capsule well, so I'm not using the the dye to stain the anterior capsule. You have to be very gentle because you need a good well-centered rhexis. Doing a good cortical cleanup again is mandatory. So the axis was 92. So you see that the lens is placed in the axis. So I decided to do a posterior capsulorhexis. Again, gentle to do a good centered rhexis, followed by vitrectomy. You can see the well-centered rhexis and the lens is in position. This child is almost followed up for 6 months and the lens is very well centered. There was also a study done in Russia, a group of toric lens, and I think it's Maria Uge, something like that, I'm not getting the name. And she has said that initial few cases she has done a posterior rhexis, but now she's deferred because of the decentration. She prefers to put the lens, and then later on after 6 months or 1 year, if there's a PC opacification, you can take in for a plas plantar vitrectomy later on. So to conclude, toric IOLs can be a choice of procedure in older children because it definitely reduces the postoperative astigmatism and increase the uncorrected visual outcome. So yes, multifocals and torics do have a place in pediatric cataract management, but the choosing the right patient is very important, and how comfortable you are with the procedure and proper counseling of the patient. Because when you do a premium lens, their expectation is much more, and then you would have sometimes problem, and keeping their living years in mind, you cannot do something which is especially when you're dealing with children who cannot come for follow-up. It's always better to do a monofocal with a good primary posterior capsulotomy and give them glasses rather than doing a premium lens and creating more trouble for the child. Thank you.